Dr. Parikshit could not log in. He's still busy in clinic.
Okay.
It is my pleasure to introduce our next speaker. As Sonu has already mentioned, Dr. Kapil Vohra is a very well-known and senior ophthalmologist. He is a medical director and foundation and the founder of Kapil Eye Hospital. He has conducted thousands of surgeries across the country of course, in his own hospital. That is very obvious. He also worked as research officer in ICMR Department of Ophthalmology and Medical College, Bhopal. Earlier in his career, he was a lecturer also in MGIMS in Wardha and served as chief eye surgeon in the Philadelphia Hospital, Ambala City for several years. His achievements include he's the secretary of Haryana Ophthalmic Academy, and most importantly, he was also awarded and recognized by the IIRS President Gold Medal and the Dr. Om Prakash Gold Medal. So we hand over to Dr. Kapil Verma to give his talk, which should be almost sort of a mastery of how to put in the lens into the eye, the ICL into the eye.
Evening, are you able to hear me?
Yes, sir.
Yes, sir, loud and clear.
Thanks for the kind words. And this is in a movie format. Can you see my screen now?
Yes, sir.
Yes. Okay. Okay. All right, sir. So just to say a few words before I start, that we have been doing the ICLs for such a long time now, all of us, that we all have developed our own techniques, and a few modifications here and there are still safe. And now I start with my presentation. So we'll cover it under 3: immediate preoperative preparation, ICL loading, and the surgical technique. One thing I would emphasize upon is the very sharp blades and perfect instrumentation, and we have to examine our disposables and instrumentation prior to the surgery. So this is a drag. This can happen even with the new knife. Please don't use such knives. We have to use very good knives. These are the disposables which you get along with the ICL. These are a multiple use injector, a single use foam tip plunger, and a cartridge. So make yourself aware with this. You might need one of these tuckers to tuck the haptics of IOL. And the most important thing is be aware of the orientation of the lens, the leading right and the trailing lower left. These have marks, and whenever the lens is opening, we have to make sure that these are opening in the correct orientation. So proper loading is essential to prevent damage to the delicate ICL and proper insertion. So this is how I load my ICLs. I still use the foam tip plunger to take out the ICL from the vial, balance it onto that, and then I put it onto the cartridge.
Kapil sir, your video is not running.
Video is not running.
It's running.
It's running for us. It's running.
It's running.
Okay.
Running very well.
Sir, it's fine. Fine.
Should I continue?
Yeah, please.
Okay. So this is how the ICL is to be loaded. Then you can take an ICL forceps, catch hold of the leading optic haptic part of the ICL and just pull it gently and leave it a little short of the tip of the ICL. I have to push it back now here slightly. And then this is the injector, and this is the foam tip applicator or plunger, which is being inserted. And once this is fixed with the click sound, we can now put the cartridge and lock it. And this is how it is loaded. So this is the surgical technique which I use. This video is around 15 years old. A slight slanting, one port I make only. And this is 1% lignocaine which I use. And at this point of time, I inject methyl cellulose. I still use methyl cellulose. And giving support to this, with the main port, you have to be very, very careful. And once I have pierced the decimates, become even more careful. Use 2.8 to 3 millimeters. And here I make the chamber still deeper. I will tell you why, because this technique has helped me. Now, a small part of the tip, as we were discussing, it has to be inside the anterior chamber and wait for the ICL to open up. So this has opened up with correct orientation. You can see the trailing haptic with a mark. There's another insertion. Again, I'm going very slowly, but here, since the wound was small, I was extra careful. And I saw that this ICL is not opening somehow. But then I saw the leading right and the orientation was correct. So I waited. And many times it needs a slight nudge so as the ICL opens up. After this, I still use the main wound to tuck the trailing haptics, and while trailing this, we lose some of the methyl cellulose, and it becomes again very convenient to tuck the leading haptics in. And I use only single port. I don't make two side ports. The lens is oriented, and then I am pressing the wound to make the methyl cellulose escape the viscoelastic as much as I can, and then the irrigation and aspiration. I still use coaxial, and I am very comfortable with it because it helps me remove the major portion of viscoelastic. And this is where actually the surgery stops nowadays. But as you must have noticed that this lens has no central hole. This was a pre-Evo era lens. So this is where the surgery stops nowadays. You don't even inject pilocarpine. But in hyperopes, that is why I selected this. You still have to make a peripheral iridectomy even nowadays. So after putting some pilocarpine, I wait for the pupil to constrict and then make a mid-peripheral iridotomy in case of hypermetropes. Again, some irrigation aspiration, and your surgery is over. So, some wound hydration. And in the post-operative phase, you have to check the vault, which in my case, I'm very comfortable if it is around 250 and above. Thank you.
Thank you, Dr. Kapil, for that wonderful presentation. So can you stop sharing the screen, sir?
Yeah, sure.
So over to Professor Dr. Namrata Sharma and Dr. Sudhank Bharti. Ma'am, your quick comments.
I think Dr. Kapil Vohra, the hurricane from Haryana, as it's known, does all surgeries so quickly that, before you just blink, it's already over. So
True.
great surgeries, I should say. Only a few points. If you're just beginning to do your surgeries and switching over, say, from cataract surgery to ICL surgery or phakic lens surgery, you have to unlearn your steps of phacoemulsification. Like when you're making a wound, you can't, dive down, because that is your instinct when you do a cataract surgery. You have to fly like an aeroplane, up, so that you don't hit the lens. Also, when you're making your incisions, you cannot be radial. I think beautifully demonstrated by Dr. Kapil Vohra that you have to make them slightly straight and not make them radial at all. The loading of the lens was, I think, very elegant, shown in a very elegant manner, and he didn't show viscoelastic. I normally would like to put viscoelastic first into the cartridge from the front and also from the back, and then put the lens. But I think some people can just do it without. And then and as you pull it gently, the other hand also moves in the opposite direction, so it kind of just helps you to pull it better, because ICL is a material which has some kind of a resistance, doesn't get pulled that easily. And then, of course, whenever you put that, you've loaded the lens already, you have to put it in a bottle which has saline till the time that you make the incision. When the pupil is very dilated, sometimes it becomes very difficult, because you can't make out where your iris is, and then you can't make out whether the haptic is actually, or the leading edge or the trailing edge is actually tucked inside. So I think that can be one tricky situation. But and of course, like I always say, and Dr. Tityal sir has also published a study, and we've done it, where if you have an intraopposite microscope, you can actually see the vault of the lens, and you can see whether the vault is adequate or not, and also can see whether the viscoelastic has been completely eliminated from between the lens and the crystalline lens or not. So that is a useful tool to have if you are, a beginning surgeon.
Thank you, ma'am, for bringing so nicely those wonderful points. Yes, Dr. Bharti, sir.
Yeah. So First thing, Kapil, a wonderful surgery. I must appreciate. It was a very nice demonstration of the ICL surgery. Couple of things which I would normally do and want to, kind of convey to the audience. One thing is that I think what was earlier said is 3.2 incision is wonderful. Minimum 3 one should keep, because the cartridge should enter the tunnel and not remain. Tunnel should not be used for injecting, because if the ICL opens outside, it's a big mishap, and then while injecting or taking it out, it is possible to kind of damage the ICL. About the loading, what I do is I put a little bit of viscoelastic on the edge of the bottle, and then if you take the ICL out, the ICL is always already painted on all the sides with the viscoelastic. So if you hold it with the wick, which is given with the ICL will never fall, because a couple of times it happens that if it is not sticking to the wick properly, injector properly, then it falls and you don't have at that point in time a replacement of the ICL. So that's what I have seen, that that gives a lot of confidence. Even if the ICL slips a little bit, it doesn't fall at all. Also open the ICL over the eye and not beyond the sheet, so that even if it falls, it doesn't fall out on the floor or somewhere where you cannot pick it up and use it. The second thing is, what I would do is I would inject half of the cartridge with the viscoelastic. The HPMC is the best, and then fill it up with the BSS, so that the HPMC is diluted about 50% or more, or maybe 30% HPMC is only there, and then you can kind of inject the ICL. I always inject it with the viscoelastic, but as soon as I inject, because I am very particular that the AC should not, kind of get shallow while I'm injecting. Third thing is, when I have injected the ICL, I press the inferior, lip of the main port. As soon as you press the inferior lip of the port, the viscoelastic from behind the lens comes out. It is not from the front that comes out first. It comes out, what comes out is from behind the lens. And that is the most crucial thing, that you take out the as much viscoelastic from behind the lens as possible. And then while washing, keep the irrigation port right in the center, you know, uh, aiming towards the central fenestration in the ICL, so that whatever, and you can really watch it. As soon as the flow of the fluid, the BSS goes through the hole, you can see that the viscoelastic is getting spread, and you can see that in the center there's is coming, and BSS coming in the behind the lens, and then you see that everything is getting washed out. So those couple of things will take care of post-op rise, post-op inflammation, post-op fibrin during the after the ICL. So those couple of things you have to be very careful. And then the best thing which I appreciate is the incision, side port incision, which was made by Kapil. It was directed towards the iris and not towards the lens. Both ways it is safer, and also it is not radial incision, but the direction towards the iris. It gives you a more controlled, possibly rotation of the ICL, because your direction towards the periphery and not towards the center. That is the very crucial thing which Kapil said. Wonderful video, I must appreciate. Thank you very much.
Thank you, sir.
So I would just chip in to bring in a point. He beautifully demonstrated the way to do a PI in cases of hyperopic phakic IOLs, which do not still have a central hole. Namrata ma'am, would you do a vitrectomy cutter, a PI, or you would use your forceps? I mean, what is your choice of doing a PI?
So when we were using lenses which didn't have holes in the center, we were doing a PI with a YAG preoperatively for all our cases.
Bharti sir?
Excuse me. What I do is I do it with a vitrectomy cutter and put the cutter at a rate of 10 with the Alcon machine. So it starts sucking the the periphery of the iris in the port and then cuts once, and that gives you a wonderful PI, which is very nice. In hyperopic ICLs, you must do a PI. YAG PI, you have, I think once a couple of times, my YAG PI is closed after 7 days. So, and we were planning to do a YAG PI before 7 days before the ICL surgery. So that is why I would rather prefer a larger PI with the vitrectomy.
So I think points very well brought that it refers from the cataract surgery. It has not to be the wound assisted, and as rightly said by Namrata ma'am, the direction is very important. You don't have to direct it towards the lens, but it towards the cornea. So I think thank you, Kapil sir, and thank you. Yeah, sir. Quick. Yes, sir. Ramamurthy sir, please.
Yeah, it was beautiful video, Kapil, and the direction of the incision, I mean, was very well illustrated. But though I have not had this problem in ICL, I've had cataract patients where I've touched the lens capsule with while making the incision and created a small nick in the anterior capsule. Obviously, if it's an ICL, the case is over if that happens. So nowadays, what I do is not to dilate these patients at all preoperatively. I just make the two side ports, then fill in a little saline so that the pupil doesn't even dilate, and make the main port, and then inject Xylocard or Phenocaine. And these myopic patients, the pupil dilates very well. So my incisions are made with the iris coverage so that the touch of the lens capsule is sort of avoided. And as regards Namrata's comment about the hugely dilated pupil, that's because of excessive fill. Whenever I face that problem, I just burp out a little visco, and you find that the pupil comes down and the edge can be seen.
Points well taken, sir. Yes, sir, Partha, sir, please. Sir, you have to unmute, sir. Sir, unmute, sir.
Yeah, okay. So just one or two small points if I could make. One is about, we learned the phakic IOL or the ICL with the methyl cellulose. And it was a very standard teaching, the optimal fill of the anterior chamber. So that is how we learned, is to put in the methyl cellulose and see the strings of methyl cellulose, and once they were coalescing with each other, to stop at that point. So the overfill is avoided there, and also the underfill. And I also personally tap the eye a little bit just to see it's not overfilled, because an overfilled methyl cellulose, then the ICL does not unfold itself very well. Whereas if it is optimally filled, it unfolds very nicely, and you can see not only the right foot plate going in and the mark on the right foot plate, but also the holes, which should be absolutely center and on the top. So if it is a little on one side or the other, you can, as very rightly said, the wrist can be turned and you can have the ICL folding right off. The other point that I wanted to make is about the PI. The hyperopic lenses do have the PIs that have to be done. Now, I use a slightly different technique, and I try and make the PI a large one, but at the periphery. So how do I do it is, like I approach the root of the angle by directing my side port from the cornea to the root. Meaning it is absolutely reverse to doing a PI, what we do in a cataract incision. So it's from the limbus to the cornea, whereas here the PI is directed from the cornea and directed towards the root of the iris. Thereby, I'm approaching the root of the iris, and then I pick it up with limbs forceps and do a PI, which is nice and large, yet hidden from view. So this is a small technique that we had described, and it was published also, and it works extremely well. One thing you have to be very careful, you should not tug the iris too hard, otherwise you might have a bleed, or you might actually damage the root of the iris. Third thing, a quick comment from maybe Dr. Ramurthy sir. Dr. Ramurthy sir does a large number of IPCLs also. So we've been talking about ICL, which has been there in a very time-tested lens, but the IPCL is also a lens that is widely used in India. And so if you could comment about the IPCL maybe.
Partha, you're
yeah.
forgetting the sponsor now. Anyway, Dr. Ramamurthy,
Thanks, Namrata.
I know your comment is going to be guarded after this.
So you're putting me on a spot.
Yeah, I
See,
am putting pressure on you.
I use both ICL and IPCL almost in equal measure. So appreciate both the lenses. And I believe that the Indian phakic intraocular lenses are also pretty good. They have come of age. And the only concern I used to have is that while the ICL is tried and tested material of polymer, while these lenses are made of hydrophilic acrylic, but now having experienced these lenses for 6-7 years and is widely used across the world, I have no hesitation in using these lenses. As I already mentioned, one of the concerns you must have is that the stud that you have to indicate the right opening is on the left leading edge in the IPCL, and you should be cognizant of that. While in ICL, the hole is in the right leading edge and the right haptic. And secondly, what I find is that as far as loading of these IPCLs are concerned, no viscoelastic is to be used. Basically, you just use VSS, and there is a coating within the cartridge itself, and that sort of mixes with the VSS, and that allows for free passage. And in case you have used viscoelastic, you often find that injecting of these lenses becomes a little difficult. The injectors that come with these lenses are not as good as what comes with ICL. That's the reason that most often these manufacturers give two lenses at the same time, and you once you are not used the second lens, you return it back. And secondly, many of these lenses are custom made, and in case you have extreme powers, you can again pre-order these lenses and get them. Even high astigmatism up to 8 or 9 doctors have used these lenses. And as far as the optic size of these lenses is concerned, that's even bigger than the EVO lens, which is 6.1 millimeter. That's obviously an advantage when you get high mesopic size pupil, and sometimes you can get even bigger size than that. Another advantage is these lenses are just 0.25 millimeter steps. So sizing these lenses can be even quite accurate, and no rotation is necessary in toric lenses because you can place these lenses in 0-180 degrees axis. So I believe that it's again good that we have choices, and the ICLs with its time-tested technology, more than a million lenses, 30 years of history, it's a great lens to be with. But it's good to have our own indigenous lenses, which are more cost-effective and which are again getting proven to be quite accepted as far as the patients and surgeons are concerned.
Dr.
So,
Ramamurthy, any
quick question.
experience of explanting these lenses? Any experience of explanting these lenses?
Yeah. I have
As it is
expanded
ICL?
ICL, yes, I have expanded both ICL as well as IPCL. Both these lenses do come out through a 2.8 millimeter incision itself. And all I do is to just pull out one haptic and then go with the front loading forceps itself and just catch hold of that and bring it out. And it just folds on itself, both a hydrophilic material. So it folds on it and easily comes out.
Do you think there's a difference in ease of explantation of ICL vis-a-vis IPCL?
I really have not done a study in that because I fortunately have not explanted so many lenses, but then I really have had no problem. As far as I'm able to fill in the anterior chamber nicely with a viscoelastic, I don't even bring out the entire lens into the anterior chamber. Just to go through a side port and prolapse out one haptic, and just go in with the front loading forceps and just catch hold of it. And then with a hand over hand maneuver, bring it out. And I find that both these lenses come out equally easy.
Last quick question from the audience to Dr. Kapil Vohra. If you have patients with large pupil and you're planning a refractive procedure, so what would be the procedure of choice? Would you still continue with ICL?
Maybe no. I would not like to put even an ICL in such case, and even LASIK will be a risky proposition in such a case. And actually, I would also like your opinion, but many a times in the borderline cases, I prefer ICL over LASIK.
So I think with the new Evo Vision series, they have on the corneal plane, they go as high as 7 millimeters, which by any refractive platform, we can't really approach. So I think Evo Vision could be a wonderful suggestion in these large pupil patients.
Evo Plus varies from 0.3 to 0.7 millimeters, a wider optical zone. maybe it takes care of many patients, but still what I have seen is that in such a case with very big pupil, if you do a LASIK uh, and versus the ICL is better tolerated. This is in my experience what we have done here.
No, I think what Sonu was mentioning was that when you have 6.1 millimeter optic diameter, the effective diameter that you get on the pupil is almost 1.25 times.
1.25, yeah.
Which makes it about 7.5 millimeters.
Yeah.
But in these large pupils is one indication for me to go for a Indian lens, because here you can get custom-made lenses without really enlarging the overall diameter. You can have the optic size as big as 6.8 millimeters even.
So I think
custom-made lenses in such cases, sir, and they do behave well.
Yeah.
I think lens-based procedures would be much better off than the corneal-based procedures in a large pupil size. That is what
I do agree. Yes.
Otherwise, also, I think the contrast sensitivity and the abrometry values are much better for lens-based procedures as compared to for LASIK procedures.
Very true. So thank you, Kapil Vohra, sir. Thank you, Dr. Namrata. Thank you, Dr. Sudhank Bharti. And yeah. A quick word from Dr. Nandipur, sir. Yes, sir, please.
Dr. Sopshila asked me the role of phakic IOLs in pediatric population. But well, I'm not very enthusiastic about using a phakic lens in a pediatric population. I would certainly like to know about the expert panel on this. I have not used and I'm not very keen on using. But what's the opinion of the other panel?
So I've been using for emblyopic patients, sir, where an isometropia is there, and the population has really improved, and they really work well. Dr. Mahipal, sir, any quick comment for this, sir?
Yeah, so on pediatric cataract, all that I'm trying to say is that even though we are not getting cataract to that extent, but now since it's been almost two decades, we are getting cases even around 40 years of age. So 35 to 40, 42 are developing. At that particular time. So I'm just a feel that I am getting. I don't have, that's why I said I don't have any scientific literature to support that, but that's just a little feel that I'm getting, that maybe it might induce because after all there is something that is sitting on the lens, even if it is in the periphery. It's not in the center that's happening, but it's in the periphery, and there could be some small little changes which are happening which could actually do that. But overall, I think even if a cataract comes, it's really not a problem to remove this lens and do a cataract surgery, because there's no problem in IOL power calculation, etc., etc. So that's a much better problem to have than having a problem of corneal ectasia or something like that.
So, sorry to be taking up time, but since you brought this up, I mean,
sir, looking to the paucity of time, I'll shift to the next. Sorry for that, sir. Thank you.